Today, we're going to have presentations by the residents. First, Justin Nguyen, PGY4, is going to present about focal therapy for prostate cancer. And then Stephanie Hanchuk, PGY3, will present on the effect of the microbiome on kidney stone pathogens.
So as Marianne so kindly introduced, I'm Stephanie Hanchuk. I'm one of the third-year residents here at Yale Urology, and I'm going to be presenting today on Beyond the Gut, the role of the microbiome on kidney stone formation. So here we have a 38-year-old male with the past medical history of nephrolithiasis who presents to the emergency room at Yale for the second time this weekend with acute left flank pain associated with nausea, presumed to be renal colic. He has seen a urologist in the past after spontaneously passing a stone last year. He completed a 24-hour urine, which was significant for low urine volume and hyperoxaluria. He reluctantly admits that he has only been drinking 2 cups of coffee a day and 1 bottle of water in the afternoon, except when he has a few beers on the weekends. His diet is primarily New Haven pizza, and he strongly dislikes citrus fruits. He recently started taking stone breaker pills when his friend's mom suggested them at a holiday party last winter. He asks you, as his urologist in the ER, why does he keep forming these kidney stones? He knows his diet isn't perfect, but he has plenty of peers that have similar lifestyles who aren't forming kidney stones and ending up in the ER every few months. He really wants to know, with all the fancy science we have in 2022, why haven't we figured out any better ways to help him? And so I present to you on the gut axis and how the gut microbiome impacts kidney stones. Starting in the 1990s, the idea of the gut-kidney axis was postulated, which is something we've been working on in the background as dietary recommendations to prevent stone formation are abundant. They also have seen that there's a reduced microbiome diversity in kidney stone patients. A lot of this work has centered on one strong suspect for a lot of this work as the bacterium Oxalobacter formogenes, a gram-negative anaerobic gut flora that primarily uses oxalate as its energy source, was postulated to be a protective factor for the occurrence of nephrolithiasis in the 1990s. In the last 15 years, the incidence of kidney stone prevalence in the United States has doubled. Epidemiologic data has confirmed that there's a propensity to form deposits in the urinary tract that's dependent on both intrinsic factors, known as we see here of gender, right? Male versus female predominance, age greater than 30, ethnic differences, and family and personal history. The question I have here is maybe there's a 5th intrinsic factor. Maybe there is something about our biology, about our microbiome in the intestinal tract that's also contributing to the kidney stone formation. The extrinsic factors we all know well, and we counsel patients on at every single visit to mitigate their risk of kidney stone. As we know, the Western diet, decreased fluid intake, high salt, low calcium, high protein, low citrus fruits, having a high BMI, metabolic disorders such as diabetes, and recurrent urinary tract infections are all extrinsic factors that we work on mitigating every day. As we know, the AUA guidelines suggest that all stone formers should be advised to drink enough fluids to achieve a urine volume of at least 2.5 liters daily. Sometimes I feel like a broken record in clinic repeating this over and over again, and especially hearing our patients who suffer often from other urinary complaints such as overactive bladder and BPH, who are concerned about their frequency, say to me, I'm so reluctant to drink this much water. I'm already in the bathroom all day long. I'm leaking urine. What else can I do? So I feel that the compliance with this recommendation is actually quite low in our patient populations. So I'm sure patients, after hearing us opine about how much water they drink, then turn to Google and ask themselves, what else should I do to prevent kidney stones? It took me 5 seconds of a Google search to find some of these posters proclaiming the diet for kidney stones, what you should have, what you should avoid, and amazing foods to prevent kidney stones, including water, which we recommend citrus fruits, and actually potatoes, which probably to our patients would mean an extra helping of French fries with a large dose of salt with their burger at night. Nutritional imbalances such as poor hydration, high salt, high animal protein are considered main risk factors for calcium oxalate stones. So patients with calcium stones, high urinary calcium, should be advised to limit their sodium intake and have a recommended daily allowance of normal calcium. So we spend a lot of time talking to patients about these recommendations, but how does this actually work out in the pathophysiology? What happens after they eat high salts, after they eat rhubarb and chocolate and almonds with high oxalates, after they don't drink enough water? That's kind of the question that this has turned to. So as I mentioned, everything that you see below, you get an oxalate load and a calcium load. These are then digested through the stomach into the intestinal tract, where they kind of come up to two fates. They can either be excreted through the intestinal tract and out and through the feces, or they can be absorbed. Those are the two main things we thought. But I think a lot of people were dismaying the bacterial network that is very rich and prevalent in the intestinal tract that also plays a role in how our bodies handle these macronutrients. As nearly 80% of kidney stones are composed of some component of calcium oxalate, there's a real importance in understanding how these metabolites are processed by our bodies, with the thought that if we could understand this better and understand how to change this, we may unlock the next breakthrough in kidney stone prevention. As you can see here, the reduction of oxalate absorption to the kidneys based on this bacterial network could be a great and very interesting pathogenesis to figure out to try to contribute to kidney stone prevention. It's not too advanced for me. There we go. So the star of the show, the original research here, was formed on Oxalobacter formogenes. This is a human gut microbiota that's really interesting to us because it's a bacteria that uses oxalate as its primary energy source to produce ATP. As it consumes oxalate in the intestinal tract, it's thought to decrease the availability of oxalate for absorption and eventual excretion into the urine. In addition to this, it also appears to stimulate the intestinal receptors that secrete oxalate, which also may ultimately reduce urinary oxalate. So it's kind of working on a two-factor system where it's metabolizing it itself as an energy source, and it's also promoting secretion. This oxalate degrading capacity of this gram-negative anaerobe in our gut flora has led to the assumption that calcium oxalate nephrolithiasis could be associated with patients who have an intestinal depletion of this bacterial flora. So indeed, that's what studies have started to show. This study in the Society of Nephrology journal hypothesized that the colonization with Oxalobacter was indeed associated with a reduced risk for calcium oxalate stones. They did a nice sized case control study where they looked at almost 250 adult patients who have calcium oxalate recurrent stones and 250 age, gender, and region match healthy controls. The methods they used to study this, they looked at the fecal microbiome by PCR. They did a 24-hour urine collection, which, as I note, only 50% of the subjects in this study were able to be compliant with. And they looked at recent antibiotic use and diet, which were self-reported measures. The results indicated that 37% of the controls were colonized with Oxalobacter formogenes, as compared to only 17% of the case kidney stone patients. So the final conclusion was that individuals colonized with Oxalobacter have indeed a 70% risk reduction for being a recurrent calcium oxalate stone former. A number like that sounds amazing. If we can reduce our patients' recurrence of kidney stones by 70%, so that's definitely something we should be looking into. But they snuck in this other line here saying that there was actually no difference in oxalate excretion between those colonized with and without Oxalobacter. So that got me to thinking, so if we're colonized, we have a risk reduction, but it doesn't actually change oxalate excretion. We're not really understanding the overall pathophysiology of how this all puts together and leads to the formation of calcium oxalate stones. This turns out to be something that was panned out in multiple literature sources in like the late 1990s and early 2000s, which believe that Oxalobacter is indeed less prevalent in stone formers. The problems with some of these studies, as highlighted in the notes section, is you can see a variability in the patient populations. One study didn't even use participants who had kidney stones. The cases were homogeneous in age and gender. Some of them used specific patient populations, including cystic fibrosis and inflammatory bowel disease patients, who we all know have a different absorption pattern of salts and different nutrients. Some of them had an absence of genomic methods to pick up the Oxalobacter. So even though this had a positive signal and it was really promising at the start off, if you looked through the papers that were actually being published at the time, there was a lot of disparity in the patient populations and the different things using. So moving on from this, people put their thinking cap on and said, how can we actually suss this out a little better? It seems like there's this positive signal where if we colonize the intestinal microflora with more oxalobacter able to grade oxalate, we can decrease calcium oxalate stone recurrence. So what happens if we give supplemental oxalobacter? And unfortunately, this didn't pan out to be as successful as initially thought, as supplemental oxalobacter does not indeed change urinary oxalate excretion. The color coding you find in the key findings is indicated by green studies, which were positive, which showed a decrease in urinary oxalate excretion with the supplemental pre or probiotic. The yellow showed the equivalency between the control arm and the experimental arm, and the red actually showed the opposite effect. Reading more into this, it's revealed that even though we have great ideas and some things in theory we think would be a perfect solution, actually in execution are much more difficult. There's a great difficulty in actually making probiotics that contain an Oxalobacter formaggini strain that is able to reach the intestinal flora and actually have the positive oxalate degrading and improving excretion that we would anticipate. The species is very sensitive to oxygen levels. It requires a low pH to survive. And it has pretty strict oxalate demand for growth, such that once you ingest it, and if it doesn't get enough oxalate, it won't even make it down to the lower GI tract. There's also a great intolerance overall to the species for the process, which is involved in the manufacturing, storage, and distribution of prebiotic products. So the oxalobacter isn't the only player and isn't the grand solution that we were looking for. What else can we turn to in this space? And the idea kind of came around with the microbiota revolution, where we started linking all of the microbiome to various entities of medical problems, everywhere from heart disease to cancer to diabetes, that maybe it's not just oxalobacter. Maybe we shouldn't be focusing all of our intensive research effort on this one specific species of bacteria. Maybe there's a whole link, a whole consortium of bacteria working together in the gut to change the kidney stone story. So indeed, that's what people started looking at. They started looking at this gut-kidney axis and analyzing the gut microbiota. And this nicely done case control study that had 52 recurrent calcium oxalate stone formers compared to age, sex matched healthy controls, they were able to analyze the fecal microbiome, which became only possible in the late 2000s as we started to get improving genetic and microbial profiling and what's called deep sequencing of metagenomics, and understand what's going on, along with a dietary questionnaire and 24-hour urinary collection. The data was panned out to be intriguing, which did indeed show that stone formers exhibited a lower fecal microbial diversity, as indicated by the orange line indicating stone formers. And this has been reproduced in multiple meta-analyses and systemic reviews of the literature, which shows in this graph here that adults with kidney stones and kind of level of moderate to strong evidence have either a greater abundance or a reduced abundance of different taxa or species of gut flora. And the question of how did these all play a role is when they looked in and they were able to sequence and study some of these bacteria closer, it turns out that not only Oxalobacter is able to utilize and promote the degradation of oxalates, but also familiar species like the lactobacilli and the bifidobacterium all have abilities to degrade oxalate, and working together as a unit, they're actually able to promote decreased oxalates in the GI tract. Now, after understanding all of this, you may say, all right, Stephanie, this is interesting, but I'm not a microbiologist. I'm not a nephrologist. How am I supposed to incorporate this into my patient recommendations? So I asked myself, what can we do as urologists? And looked deeper into this and said, you know, the probiotic, prebiotic space is still evolving. And I think it's a really interesting space in understanding how this all fits together. But what do we do something on a daily basis that can impact how this affects kidney stone formation? And the answer comes back to our tried and true antibiotic stewardship. So epidemiological analyses have shown that in the United States, 30% of patients are prescribed at least one antibiotic a year. Studies on the different compositions of intestinal microflora with patients with urinary stones have actually shown that antibiotic therapy is correlated with the increased development of kidney stones. And it's thought not only because it depletes the Oxalobacter colonization, but also modifies the composition of the entire intestinal flora. So something that we're doing every day, and it's not something that I'm putting blame primarily on urologists, but our patients, our kidney stone patients, are showing up to urgent care centers, the emergency room, the urology clinic. They're getting empirically treated for UTIs based on their symptoms repeatedly. The amount of patients we see that are constantly getting nitrofurantoin, Bactrim, Keflex are impacted by this idea daily. And so what we see here, and a nice study done again by our friends over in nephrology, was that indeed oral antibiotic exposure is related and correlated with an increased risk for kidney stone disease. So they found that Oxalobacter, our star of the show, is generally sensitive to the variety of antibiotics commonly used to treat urinary tract infections and pyelonephritis. They were able to utilize the UK health system and look at 13 million individuals. They then came up with two groups, kidney stone group with 25,000 patients and a control group with about 250,000, really impressive numbers here, matched on age, sex, race, and practice, and looked at their prior antibiotic exposures in 3 to 12 months prior to the index date. They chose those dates because they didn't want anyone who had antibiotics in the past 3 months, because they didn't want that impacting. They didn't want that impacting the way in which it could it changed practice patterns in thinking of patients who have recurrent UTIs or actually presented with a septic stone. As you can see, though not very well, I apologize for the graphics. In the middle is a blue graph, which shows that antibiotic classes that include, like I said before, Bactrim, Ansef, Keflex, Cipro, nitrofurantoin, broad spectrum penicillins, they all showed an increased odds ratio for being associated with a kidney stone disease diagnosis. Okay, those are all, as you can see, very small p-values, and the odds ratios are not insignificant here. On the right in the white graph, it's a little harder to see even more, but it actually shows that patients who received antibiotics in more frequency at a younger age were also associated with a kidney stone diagnosis. So now we're on to something new and saying, we thought about this Oxalobacter, we understand there's oxalate degrading bacteria, we understand that's a role in kidney stones, and then we also look and see, hey, there's something that we're doing in our practice very consistently that's having a direct impact in the pathophysiology of this process. So trying to move in a space from correlation to causation, a group in China actually did a study with rats, okay? They used 30 genetically modified hypercalciuric stone-forming rats. And they did a study to determine the effects on antibiotic use on kidney stone formation. So we have 3 groups of rats indicated by my 3 friends here on the screen. We have a control group with the guy who has no medication below him. They were all exposed to the same environment and all given the same amount of water to drink every day and the same amount in the same diet. The other 2 groups, the experimental groups, where a rat was exposed to Bactrim daily at a weight-based treatment dose, and a rat that was exposed to ciprofloxacin daily. Granted, they treated the rats much longer than we would treat someone with a UTI with an antibiotic dose. They treated them up to 18 weeks with antibiotics. But if you think about some of our recurrent UTI patients or recurrent kidney stone patients, over years and years, you could estimate that some patients have been on antibiotics for 6 to 12 to 18 weeks at a time. The experimenters collected both urine and stool samples, and then at 18 weeks, they actually did something called a faxitron to establish and look at kidney stone formation. So I don't understand the complete science behind the faxitron, but to me, it looks somewhere between a KUB meets a cystogram, retrograde pyelogram situation, or a CT urogram even. And you can see here clearly, as denoted by the orange arrows, that in the patients or the rats on Bactrim therapy, there was a significant increase in nephrocalcinosis here, as dictated by the hyperdense material on the kidneys. In the patients or the rats on ciprofloxacin, you saw a small increase in calcium deposits. And in the control study, you didn't see any. So again, this is really intriguing data to suggest that, maybe the way in which the antibiotics, either through their impact on the gut flora versus another mechanism, are also impacting our patient stone risk, which kind of doubles down and tells us we really extra specially need to be great antibiotic stewards for our kidney stone patients in importance. So you may ask the more compelling question, okay, I can do even better job at my antibiotic prescriptions, make sure patients have cultures, be treating them appropriately only when symptomatic, etc. But what about better prevention? We have probiotics, you see them on the shelves. There's urinary probiotics, there's vaginal probiotics, there's gut probiotics. What can we do? So this is, this 30-page review that detailed the probiotic space and the prevention of calcium oxalate urolithiasis. And like we said, there are probiotic bacteria that can degrade dietary oxalate in the gastrointestinal tract to be absorbed and could really help reduce urinary oxalate levels. But once again, this space is extremely, extremely fraught with difficulty in finding a true positive signal. They've looked at phase 1 trials, phase 2 trials, they've tried different supplements, and nothing is really panning out in this space. So I think there's more work to be done. I think this is an exciting new idea in the pathophysiology of kidney stone pathogenesis, and especially for our patients who we see all the time who are back and forth over and over again with kidney stones, who've tried dietary changes, who are on their thiazides, who are drinking more water, who have a lot of different risk factors, who just unfortunately are ending up recurrently in our ERs with infections and kidney disease. So I do have hope that, and so does Joey here, that one day possibly some of this research will pan out. But in the meantime, I think it's been an explosive field of interest in the last 20 years or so in looking at more kidney stone prevention as it becomes a more prevalent issue in our country. Thank you.
I'm going to be presenting on focal therapy for prostate. Okay, perfect. No financial disclosures. I'm going to start with a case. So we have a 65-year-old male with elevated PSA, no significant past medical or social or surgical history. His SHIM score is 23. He's sexually active with, and erectile function is important to him. His IPPS score is low. He got an MRI of the prostate, shows a PIRADS 5 lesion, 2.1 centimeters in the left lateral base peripheral zone. And he's got a prostate that's about 42 cc's. He got a prostate biopsy. The targeted biopsy shows 2 positive cores, 3 + 4 = 7, and 3 + 3 = 6. He also has an additional core on the systematic biopsy in the right medial apex, which is 3 + 3 = 6. He got a Decipher score of 0.49. He's intermediate risk. And so usually for a patient like this, thinking about the options, does focal therapy ever come up? Well, focal therapy has not been widely adopted due to the various challenges it's faced in the past. For example, 90% of prostate cancer is multifocal. Only 20 to 40% of prostate cancer is unilateral. Like in this patient, his is bilateral, his is multifocal. Accurate disease localization has been a challenge in the past. There's concern for overtreatment, especially in low-risk patients. And most importantly, there's a lack of high-level evidence. Looking at the prostate cancer AUA guidelines of 2017, when they directly address focal therapy, they note that it lacks robust evidence of efficacy. It's not approved explicitly for the treatment of prostate cancer. Tumor location may influence oncologic outcomes. Specifically, the apical area could be difficult to treat. Prostate cancer is often multifocal, and focal therapy may not be curative, and patients actually might require more further treatment after focal therapy. When broken down by risk and going into different options there, again, for very low risk and intermediate patients, they note that comparative outcome evidence is lacking, and so it's not considered a standard of care option. And for high risk disease, it really shouldn't be done outside of a clinical trial. So why consider focal therapy? Well, for one, focal therapy has been successfully applied in many other malignancies. We're all familiar with kidney cancer, but also breast cancer, thyroid cancer, lung cancer, all of these which were traditionally treated with radical surgery, many of these which are multifocal as well, but have found a lot of success with focal therapy. The goal is to maintain oncologic benefit while preserving genitourinary function. When you look at patients under active surveillance, while it preserves genitourinary function, it's not utilized by almost half of patients, and then another 50% end up undergoing radical treatment anyway. And when you're looking at patients with radical therapy, while it has good oncologic benefits, then you risk impotence, incontinence, and the rectal toxicity for patients who get radiation. And so focal therapy might be a nice intermediate between the two for certain select patients. The idea is to target the most aggressive lesions based on the theory that the natural disease of prostate cancer is driven by an index lesion. And then another major driving factor is patient preference. So talking a little bit more about the index lesion, this is the theory that most metastatic cancer arises from a single location in the prostate, and usually the secondary low-grade lesions rarely metastasize. It's defined by tumor volume greater than 0.5 cubic centimeters and Gleason grade typically greater than 3. And importantly, the largest volume disease in the prostate usually harbors the most aggressive disease as well. So this usually culminates as the index lesion. Identification has significantly improved with the advent of MRI targeted combined with systematic biopsies. And then for some centers, especially in the UK, they're using transperineal template biopsies. Thinking about patient preference, this is an interesting study published in 2020 doing a discrete choice experiment for patients with localized prostate cancer. They had a choice between active surveillance, focal therapy, and radical therapy. It's across 34 institutions, 614 patients of all risk levels. And the key finding here was that patients at all risk levels were willing to trade survival for GU function. In the low to intermediate risk group, they were willing to trade up to 7% of survival for function to avoid radical therapy. So what patients are actually good candidates? This consensus project tried to address that in 2017. It brought together 43 international focal experts, and they defined focal therapy as not only targeted ablations, but quadrant and hemiablation as well. They felt that MRI should be the standard imaging tool and histologic confirmation should be required. MRI fusion targeted biopsy plus systematic biopsy should be the gold standard, and a 12-core truss is insufficient. For disease factors, low and intermediate risk can both be considered. The ideal candidate would be a Gleason 3+4 with clinically localized, favorable location and size, and good life expectancy. PSAs ideally should be under 10, and you can treat cancer foci up to 3 millimeters and involving up to 25% of the prostate on MRI, as long as it's localized to one hemigland. They also noted that if you have one untreated core of Gleason 3+3, that would be considered acceptable, once again going off this index lesion theory. Patient factors are obviously important. You need to consider life expectancy, sexual function. Preservation is an important indication, but lack of erectile function should not exclude patients. Patients with mild to moderate lux should also not be excluded, and smaller prostate sizes are ideal, but you can consider a larger prostate depending on the specifics of their disease. There are multiple different ablation strategies that can be taken. The hockey stick ablation is almost a whole gland, it's like 75%. Hemiablation is just targeting the side with the lesion, and then targeted focal is targeting the lesion itself with a margin to make sure you get all the cancer. Speaking of margins, it's important to know that MRI underestimates the size of tumor, and there have been 2 good studies in the journal Urology that have shown that if you get a margin of about 8 to 9 millimeters, you should be able to achieve complete tumor ablation. As far as the different modalities, there are many different modalities available on the market. The ones that we were going to focus on are cryoablation, irreversible electroporation, and ultrasound ablation, specifically transurethral ultrasound ablation, as these are the treatments that we have here at Yale currently. So cryoablation, most should be familiar with this, using freezing to induce cell death. It's been around the longest. It was originally utilized as whole gland, but has recently been used more for hemigland and targeted focal ablation. You utilize transperineal cryoprobes using at least 2 freeze thaw cycles. You monitor the formation of an ice ball under transrectal ultrasound guidance, and you use a urethral warmer and temperature monitoring of sensitive structures like the rectum and urethra. Speaking of that, one of the main limitations of cryoablation as a thermal therapy is it does have a larger margin, and so you have to be careful when treating lesions near the rectum, nerves, and urethra. This is an example of ultrasound guidance. You can see the cryo needles within the prostate. And then these hypoechoic areas represent the formation of the ice ball. So the first study, this is a prospective case series of patients undergoing focal cryotherapy. It was published in European Urology in 2019, involved 122 patients in 5 centers. The majority of these patients were intermediate risk, some were high risk. Their follow-up time was only 28 months. They were followed requiring radical or systemic therapy, metastasis, or death. 2 were any patients in definition 1 plus requiring additional focal therapy. 90.5% of patients had failure-free survival per definition 1, with 93% of patients in the intermediate group. There were no cancer-specific deaths. They had 100% continence at 6 months, and 83.8% were potent at 6 months for the patients who completed the questionnaire. And importantly, they had no rectal fistulas. This is a Kaplan-Meier showing the failure-free survival per definition 1. They break it down by intermediate and high risk, and there was actually no statistical difference between the 2 groups. When doing definition 2, so this included the patients who had to receive additional focal therapy, 8 patients underwent additional focal therapy. Again, no statistical difference between the intermediate and high risk group. And once again, 100% cancer-specific survival, 98% metastasis-free survival, 96% overall survival. Of note, short follow-up time. So a lot of these things would take a long time to really be demonstrated. The next study is actually comparing whole gland cryoablation versus partial cryoablation, and whole gland is much more accepted and is part of the official guidelines. This was in intermediate risk patients. The outcome was biochemical progression-free survival. It was a retrospective propensity match study with about 900 men using the cryo online data registry. They had a 31-month median follow-up. They found that the 5-year biochemical free survival between partial and whole gland was not statistically significant using the Phoenix criteria. It was also not statistically significant using the Astra criteria, with survival being 75% in the partial group versus about 70% in the whole group. Looking at the biopsy rate, 8% of patients underwent biopsy for cause, and only 2% of those patients had a positive biopsy, so it's pretty good. The continence rates were not statistically different between the two, 95%, but they were significantly better in the partial group. And then as far as complications go, while there was no statistical difference between the two, no patients in the partial group developed a fistula. The next modality is irreversible electroporation. We have this here at Yale as NanoKnife. It delivers high voltage, low energy electric currents to blade tissue. This destabilizes the cell membrane, forms nanopores, and causes apoptosis. Importantly and interestingly, it maintains the connective tissue matrix, so it does a good job at preserving vessels and nerves and does not utilize any thermal energy. So the margin around the needles is very small. So the technique, very similar to cryoablation in that it's transperineal. You're using electrode needles. You deliver up to 3,000 volts per centimeter between the needles, and it's delivered in pulses, and it's done under transrectal ultrasound guidance. This study was published in European Urologic Oncology in 2020. It's a prospective single institution cohort study of patients undergoing IRE. They looked at failure-free survival, same radical systemic treatment, metastasis, and death constituted failure. Patients all got PSAs, MRIs, and everybody got biopsied at 12 months. They had a 36-month median follow-up, 123 patients. The majority of these were intermediate risk, a small percentage low risk. Again, looking at failure-free survival, 97%, 98.5% metastasis-free survival, and 100% overall survival. Of the 18 patients who did require salvage, 12 of these were actually requiring repeat focal therapy, with 3 getting RALPs, 2 radiation, 1 brachytherapy. Recurrence rates, so it was 10% in field when looking at the entire cohort. When they excluded the first 32 patients, as they actually changed their protocol and had a learning curve for the first 32 patients, it was only 3% in field, with 85% having no recurrence at all. The mean PSA decrease was about 50% at 1 year. Almost 100% were continent at 1 year, and 93% had erections firm enough for sexual activity at 1 year. And then the last modality we're discussing is ultrasound ablation. So this is using ultrasound beams that generate temperatures up to 60 degrees Celsius, leading to coagulative necrosis and cavitation. The two main modalities, high intensity focus ultrasound, also known as HIFU. This is the most studied of the two. It's been around longer. It's using a transrectal ultrasound transducer to deliver focused beams up to 4 centimeters from the source with no injury to intervening tissue. So this is an example right here. The other is transurethral ultrasound ablation, TULSA. This is using a transurethral ultrasound to use continuous sweeping directional beams, and this is an example right here. It's MRI directed, and because you're ablating the entire prostate, you use urethral and rectal cooling. So this is an example of HIFU as what it would look like under ultrasound. And then this is TULSA, transurethral, and this is the MRI, live MRI images. You can actually see where you're being treated based on a heat map, and then you can see what it looks like afterwards. So starting with HIFU, this was a retrospective match paired study comparing HIFU versus robotic prostatectomy for patients with unilateral disease. Again, their treatment failure was defined as needing salvage therapy, hormonal therapy, metastasis, and positive in biopsies in the treatment area. It was single institution, had 55 patients in each group. There was a mix of low and intermediate, with a small percentage having high risk, and the follow-up was 36 months. They found no statistical difference between salvage-free survival, cancer-specific survival, and overall survival, being 87, 89%, 100 and 100, and 91 and 80 and 98%. Looking at the functional outcomes, HIFU had better continence and potency compared to robotic prostatectomy. 95% were continent in the HIFU group versus 91 in the robotic prostatectomy at 2 years, and 80% were potent versus 56% at 2 years. Then this is a prospective multi-centered case series in patients undergoing HIFU. Again, failure-free survival had the same sort of definition: radical systemic treatment, metastasis, and death. Although they allowed up to 2 repeat HIFU treatments, included 600 patients at 9 centers. 53% of these were intermediate risk. There were some who had high risk and low risk disease. They had a 5-year median follow-up. They followed them with PSAs. They got MRIs yearly, and they got a biopsy if there was a suspicion on MRI or PSA rise. Their failure-free survival at 5 years was 88% overall, with 88% in the intermediate group, 98% metastasis-free survival, and 100% cancer-specific survival. Importantly, 25% of these patients required a repeat HIFU treatment. They had relatively good functional and outcomes and low complications. Of note, 2 patients did develop rectourethral fistula, and then 98% required no pads at 2 to 3 years. And then going to TULSA, the reason why I included TULSA, even though it's not technically focal therapy, is it's something that we're offering at Yale, and we're actually participating in a clinical trial. This was just published last year. This was the TAC trial. It's a prospective multi-centered single-arm clinical trial looking at safety and efficacy. And their efficacy was defined as a PSA reduction greater than 75%. All patients got a 12-month 10-core biopsy. At the time when they developed this clinical trial, that was considered standard. It was before MRI was widely adopted. It was 115 men at 13 centers, 67% intermediate, 33% low risk. Median follow-up was 36 months. At 12-month biopsy, 65% had no cancer, 20% had Gleason grade 1, and then 15% had Gleason grade 2 or higher. 96% of men achieved a greater than 75% reduction in PSA, with a 95% median reduction in PSA. and 7% of these patients required some form of salvage treatment. 4 of them were robotic prostatectomy, 4 of them got radiation. They had good functional outcomes. 96% of patients returned to baseline continence. 75% had erection sufficient for penetration. And then there's an 8% adverse event rate. Most of these were UTI and retention, although there were, I think, 2 patients who got urinomas. So then what about surveillance after treatment? So this was a systemic search and then consensus panel that tried to develop some guidelines. They had 17 studies, and they also looked at prior consensus papers. Of note, evidence was limited, and recommendations ultimately were mostly low grade. They defined treatment failure as Gleason 3+4 or higher in the treatment zone, although they said greater than 2 cc's, which I found a bit questionable. Untreated zone, any significant cancer requiring further therapy. They couldn't make comments on PSA due to insufficient evidence. They felt all patients should get MRIs within 1 year of the initial treatment, and any positive MRI should prompt a biopsy. They felt patients should be biopsied within 6 months, and then again at 12 to 24 months, and then finally at 5 years, and of course for suspicious MRI. And they felt a recurrence should be treated if it's Gleason grade 3+4 or higher. And focal therapy should only be utilized again if the reason for failure the first time can be corrected. And then the last study I want to briefly talk about is a systemic review that was just published in the European Urology last year. It was a protocol-driven PRIMA adherence systemic review. They had very strict protocol. They wanted only studies that did primary treatment for prostate cancer, focal therapy versus standard options that included greater than 50 patients. They were only able to find 4 studies. There was 1 RCT, but this was against active surveillance in low-risk patients. The overall data quality was limited due to heterogeneity, bias, and lack of long-term data. And their conclusion at this time was focal therapy should not be recommended outside of clinical trials or prospective studies. So what conclusions can we draw? Focal therapy demonstrates the potential as a primary treatment option for clinically localized prostate cancer in well-selected patients, but we need better criteria for patient selection. We need better data on oncologic and functional outcomes, and monitoring protocols need to be defined. And in order to do this, we'll need more robust prospective comparative studies that are measuring meaningful outcomes at long-term time points. So, a lot of these studies are limited 3 to 5 years. We need to go further out than that if possible. There are multiple ongoing and future RCTs, and we're actually participating in the TAC2 trial, which is the Tulsa trial. And that's my presentation. Thank you.
Thanks, Justin. That was a great overview. I think that one of the things that you'll notice, or that you probably noticed and just want to point out to everyone else, is a lot of those guidelines and recommendation position statements were from 2017. So that's almost 5 years ago, and a tremendous amount has kind of advanced or progressed and changed since then. I mean, still we have more longer term data. So you presented some where we now have 5-year outcomes. In 2017, we really had nothing, and we were kind of predicting what sort of things we should be tracking to be able to appropriately recommend treatment and evaluate the success of focal therapies or ablation therapies. So I think we're making progress. The interpretation of not doing ablation outside of a trial is appropriate, but it shouldn't be considered so. It shouldn't be a real high bar. Basically, what that means is you need to have a registry. So not all the focal ablation that we do here is part of a clinical trial, but we do have an IRB approved registry because we need that data, right? So we need everyone who's doing these procedures to have some regimented data collection so that we can look and eventually publish and compare all of our outcomes. Make sure that we're doing beneficial things for our patients and we don't have really high complication rates. So I think it shouldn't be, for people who are interested in this, especially if you want to be doing it, it's not saying that you can't do it, but we do need to you do want to have it be part of a registry.
Yeah, no, I thought that conclusion from that systemic review was a little strict. They said any prospective study though too, not just clinical trials, but prospective studies. But yeah, I completely agree. I think the only way to know more about this is to do more of it. So,
and really, but I agree with their findings, and quite honestly, we say that in everything that we publish and do, because we don't want people to randomly start doing this. Like, there's the significant potential for damage for this to be done in the community. And with some of these ablation technologies, so HIFU, for example, the reason that we're not doing it, I'm not a huge fan of it, is because they are trying to market directly to the urologists who have very little or no experience or understanding of how to do these procedures, and they're basically trying to make it a plug and play kind of thing where people can do a lot of damage, do poor treatment, and doing a focal treatment, yes, you can salvage, but it honestly makes salvage procedures more challenging, and you're going to have a greater negative impact on your quality of life. So you don't want to damage the long-term success of an ablation therapy and focal therapies by allowing people to sort of do it poorly and have really bad outcomes, because that will obviously garner a lot of press.
Yeah, totally agree.
Hey, Dr. Sprinkle, quick question, or for Justin. I mean, how would you counsel these patients? Maybe if you're thinking of like a favorable intermediate risk patient who might be considering focal therapy, but you can also talk to them about active surveillance, about the fact that you're kind of, one of the benefits of treatment is that you're avoiding the intensive surveillance patterns and active surveillance MRIs and biopsies. But if we're kind of requiring this with focal therapy, is this a discussion that you also have with them at the same time?
Do you want to take that, Justin, or?
Yeah, sure. Yeah. So, I think, a lot of patients who don't want to do active surveillance because of the intensive follow-up shouldn't consider focal therapy, because you still need to follow up focal therapy as well. So they would still be undergoing PSAs. They would still be getting rebiopsies to make sure they don't have a recurrence. So I don't think that should be a reason to do focal therapy. But I think it's good for patients who, a favorable intermediate risk, who could be watched on active surveillance, but the patients don't feel comfortable watching on active surveillance. They would like a treatment, but at the same time, they don't want to undergo a radical treatment that could, significantly worsen their rates of erectile function and potentially continence. So I think those are really the key group of patients who would benefit from this the most, because they would get some form of treatment to kind of quell their anxieties about just watching cancer, but at the same time, they would be able to preserve a lot of their genitourinary function potentially. I mean, there are still side effects with focal therapy. It's just better, just tends to be better than a radical treatment.
So I think, yeah, you're right, Justin, just to add a little more nuance. So I think, Danny, I don't know if you're specifically thinking of a 50-year-old guy or in his mid-50s who is looking at being on surveillance for 5 to 10 years of repeat biopsies. The number and intensity of biopsies after an ablation is less than that. So, I mean, my personal protocol is I do a repeat biopsy currently at 6 months and 24 months, but then do not do repeat biopsies after that if their PSA stays stable and low, and would only I use PSA as a trigger. No matter what, after prostate cancer, you're going to get PSA. So if they're really worried about the biopsy frequency and number of total biopsies, it would be less after having an ablation therapy than being on surveillance for more than 2 years. So I don't know if that kind of answers your question. I think, I still counsel most of these guys with favorable intermediate risk disease to strongly consider active surveillance. And if they are really, because it has the least impact on urinary and sexual function, and it really should have minimal or no impact. It is the psychological stress of having a prostate cancer diagnosis and having a prostate biopsy on an annual basis. If they're really bothered by it, then we talk about treatment. I think my counseling for these patients is really, it's a great option if you really want to preserve your quality of life in the short term, and it's not as effective as Justin mentioned in terms of cancer control. So I usually quote about an 80% 80% success rate, so freedom from needing retreatment, and that includes the low rate of recurrence in the area of treatment, but also that 10 to 15% rate of recurrence out of field, which seems pretty consistent. And that's usually in 1 to 2 years. So we do need the long-term data. This is not a replacement for surgery or radiation. This is a kind of a mitigating step. For some people, it may long-term be a cure. That's great. I think that overall that number is probably going to be low. And we're going to try to find that sweet spot for people, right? I mean, this gives people many more opportunities and options to figure out how they want to treat their disease. Did that answer your question, Danny?
Yeah, great, thanks.
So in terms of trials, I'll just pipe in for a second before we're done. So the TACT 2.0 trial is an extension of the TACT trial that Justin described. That is a just monitored trial and then with low and intermediate risk prostate cancer. That actually is closing the end of March. So we are finishing accrual on that. We do have actually a randomized trial called the CAPTAIN trial, where men with intermediate risk, so grade group 2 and grade group 3 disease, will be randomized to either TULSA or radical prostatectomy. And it's a 2-to-1 randomization. So every 2 people that get TULSA, 1 will get prostatectomy. It's going to be a long-term study. This is one of those long-term randomized trials that we hope will help clarify what the long-term benefits of an ablation therapy, so long-term urinary and sexual function benefits are, and hopefully we'll have a limited negative, not negative impact, but hopefully the lower rate of cancer control will not have a significant impact on long-term survival. I mean, I think that's the best thing that we're looking at. I mean, clearly it's going to have a higher rate of biopsy proven recurrence. There's no prostate to rebiopsy after prostatectomy. Even in radiation treatment, we don't routinely biopsy people again. Interestingly, for those of you who may or may not have.
My apologies. I couldn't hear what you said.
Sorry, Siri's cutting in there. But for even for the people who had radiation, there was a study where they did a biopsy at 6 months after radiation therapy, and almost 50% of those people had prostate cancer detectable on biopsy. So it's
And then I actually got a direct message from Dr. Miller. He was asking about focal brachytherapy, which is different than traditional brachytherapy in that you are only placing the brachytherapy beads at the sites of the recurrent of the prostate index lesion. I did not specifically focus a lot on that. I did see a little bit of data on it in some of the review studies I was looking at. And it was the results seemed pretty similar to all the other focal therapies. There wasn't a lot of long-term data. They seem to have pretty good rates of continence. Interestingly, they didn't report erectile function in, I think, the 2 studies I was looking at. They were retrospective in nature. And they had short outcomes. So they had good cancer-specific survival, but obviously they weren't following them long enough to really see a difference or make any definite conclusions. I don't know if you've know more about focal brachytherapy, Dr. Frankel.
So we're not doing it here at Yale. Obviously, we do not currently have a brachytherapy program. The overall take on brachytherapy is you really want someone skilled and who does a high volume if you're going to have them do that. There was and may still be a trial at Memorial Sloan Kettering where they're doing focal brachytherapy. If the patient is interested in that, I happily refer them there. I may be incorrect, but I would hope to be corrected if anyone knows better. but I don't think there's anyone in Connecticut that does a high enough volume of brachytherapy that any of our patients should be getting brachytherapy in the state of Connecticut. I mean, they really, if they want brachytherapy, they should be going to Memorial. I don't even know if they do it in Boston much. I know they do a lot of external beam, but you really want someone who's good, because the complications can be very significant if the seeds are placed incorrectly.
There are some Boston providers that do it out at this side of the state. That's where people go. But I think you're right. And doing it certainly with any frequency.
Are there any other questions?
All right, thanks, Justin.
All right, thanks, guys.
Thank you,
I think
everyone.
this is here to stay. So, I'm happy to talk to people about it if they're interested in getting involved. This is going to be it's early, but it's going to be a larger part of I think the practice for urologists, and it'll probably make it more accessible to people who aren't necessarily active surgeons. I think a lot of this could be done potentially in the office or definitely in a surgery center.
All right, thanks, guys.